Welcome, and thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Bristol Myers Squibb, Jazz, Novartis, and Taiho for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Brandi Reeves, a physician scientist at the University of North Carolina, Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina. As a clinician investigator and co-principal investigator at UNC Lineberger, an MDS Foundation designated Center of Excellence, her clinical interests are focused on myelodysplastic syndromes, myeloproliferative neoplasms, and other bone marrow failure syndromes. She provides clinical and research expertise for these patients with a goal to improve the treatment of patients with MPNs, MDS, and bone marrow failure syndromes. She is also dedicated to training the next generation of physicians and is involved in medical student, resident, and fellow education. With that said, it is my pleasure to introduce Dr. Brandi Reeves.
Thank you for having me today. My name is Brandi Reeves. I'm an assistant professor of medicine at the University of North Carolina at Chapel Hill, where I clinically focus on seeing patients with lower risk myelodysplastic syndromes as well as myeloproliferative neoplasms. And today I was tasked with talking about fatigue and anemia in myelodysplastic syndrome, and in particular, the benefits and risks of blood transfusions. So a brief overview, we're first going to start by exploring the prevalence and severity of fatigue in myelodysplastic syndrome. We're going to look at the factors that are associated with developing fatigue. We're going to discuss the relationship between anemia and fatigue. And then we're going to look at the benefits and risks of blood transfusions, as well as other fatigue mitigation strategies in MDS. So just how big is the problem of fatigue in MDS? Is it just you? And the answer is no, it is not. In fact, 9 out of 10 individuals with MDS have fatigue. In fact, nearly 1 in 3 of those have moderate to severe fatigue, which impact their daily activities. So what things lead to fatigue? Well, there are things that are intrinsic to each of us, or host factors, and then there are factors that are caused by the myelodysplastic syndrome itself. So in terms of host factors, the amount of activity that we perform can contribute to fatigue. So both increased activity because you're wearing out muscles, and decreased activity when you're not using those muscles so much can lead to fatigue. And vice versa, fatigue can feed back and cause decreased activity. Diet can also lead to fatigue, especially diets that are high in sugar and low in nutrients. Depression and anxiety can lead to fatigue, one of the most common symptoms in depression. And likewise, fatigue can feed back to depression and anxiety because you're unable to do the things that you were previously able to do because you're too tired. Of course, poor sleep, both in terms of obstructive sleep apnea or poor sleep hygiene, can lead to fatigue. Endocrine abnormalities such as thyroid dysfunction, problems with sex hormones, low testosterone, and hypocortisolism can all lead to fatigue. Then activation of the sympathetic nervous system, which is that part of your brain which says that you should rest and digest. So the thing that kicks in after Thanksgiving dinner can lead to fatigue. And then other comorbid conditions. So heart failure, diabetes, rheumatoid arthritis, lupus, all can contribute to fatigue as well. For the MDS-associated factors, anemia or low hemoglobin can lead to fatigue. Inflammation is present in myelodysplastic syndrome. So those abnormal stem cells in the bone marrow make inflammatory markers that can cause fatigue, very similar to if you were to have an infection. So we all are very familiar these days with COVID. So COVID is a big time inflammatory state and leads to pretty extreme fatigue. MDS has similar markers of inflammation that are increased. Then higher risk myelodysplastic syndromes are more prone to fatigue. And likewise, fatigue can actually make higher risk MDS have a worse prognosis. And then the chemotherapies and treatments for MDS can also lead to increased fatigue. And in this particular presentation, we are going to primarily focus on anemia. So anemia, recall, is a decrease in red blood cells, which in general on your complete blood count or CBC is typically measured by hemoglobin and hematocrit. So red blood cells are bags of hemoglobin, and hemoglobin are proteins that really carry around oxygen. So your red blood cells are loaded with oxygen. They're circulating around the bloodstream where they go through all the tissues, and they offload oxygen to the tissues, and then they pick up carbon dioxide from the tissues, bring them back to the lungs. You exhale carbon dioxide, pick up new oxygen, and this cycles around. You can imagine that if you have fewer red blood cells, you have decreased oxygen carrying capacity, and that perhaps that would affect some of your tissue functions, including concentration with decreased oxygen delivery to the brain, increased muscle fatigue because there's less oxygen delivered to skeletal muscle, et cetera. That can also put increased demand on your cardiovascular system, increasing the amount that your heart is pumping and contributing to fatigue as well. So we know that fatigue is essentially ubiquitous in myelodysplastic syndromes. What about anemia? Well, it turns out anemia is also nearly ubiquitous as well. So in fact, nearly 90% of patients will have some degree of anemia with myelodysplastic syndromes. 63% will have moderate anemia as defined by a hemoglobin of less than 10 grams per deciliter. And at some point during the disease course, about 40% of patients will become transfusion dependent of red blood cells. So this is a big time burden in myelodysplastic syndromes. So anemia is common, fatigue is common. Does anemia drive the fatigue in myelodysplastic syndromes? Well, there have been three kind of big studies looking at this. The smallest study included 50 patients and did find that hemoglobin levels correlated with physical and mental fatigue. So anemia was associated with worse physical and mental fatigue scores. In a bigger study of 280 patients, hemoglobin only partially related to fatigue. And then in the largest study of 359 patients, hemoglobin didn't correlate at all with fatigue. So my interpretation of these data are they are as clear as mud. So a clever group of researchers actually went about asking patients themselves, do you feel any improvement if you get red blood cell transfusions? And so this was over 400 patients with transfusion-dependent myelodysplastic syndrome in the US, the UK, and Canada. And 80% of patients said, yeah, they do feel improvement in their fatigue when they get red blood cell transfusions. 20%, though, said that they felt actually worse for the first 1 to 2 days after they got a red blood cell transfusion. And about 7% did not notice any change in their symptoms whatsoever. Kind of shockingly out of this survey was that 40% of patients actually wanted a higher hemoglobin target than they were prescribed. So they felt better when their tank was closer to full rather than keeping it down here, kind of in the middle with these restrictive hemoglobin targets. And so it brings up the question of who sets the hemoglobin targets and why were those chosen? And the first thing to say is that the hemoglobin targets are actually largely based from inpatient data, where patients with, in particular, cardiovascular disease or sepsis, severe infections, received blood transfusions. And in that inpatient population, we know that lower hemoglobin thresholds tend to have better outcomes. But we also know that myelodysplastic syndrome is not really a disease that is treated in the hospital. This is a disease that is outpatient and chronic. So it would be nice to know if that warrants a different hemoglobin threshold. So in this pilot study of 38 patients with transfusion-dependent MDS, this group in the red study actually used a restrictive transfusion target of hemoglobin 8.5 to 10 grams per deciliter versus a liberal transfusion target of 11 to 12.5 grams per deciliter. And what they found was that really in all aspects of quality of life performance, those who had higher hemoglobin targets felt better. And that includes in fatigue, in shortness of breath, physical functioning, and in how they felt kind of globally. And so this brings into question, should we have perhaps higher transfusion targets for our patients? This is a pretty small study and certainly merits additional consideration in a larger trial. So why then do clinicians really hesitate in terms of getting hemoglobins in this 11 to 12.5 range? And most of the time, patients are getting transfused for hemoglobins of 7 to 8 grams per deciliter. Well, it turns out it's in part because there are lots of complications from red blood cell transfusions. So red blood cells are expensive. So each unit of blood actually costs the hospital about $200. And then there's the cost of testing the blood to make sure that it's not contaminated with infection. There's the cost of administering the blood as well. It's also time intensive for red blood cell transfusions. So each unit can be 1 to 4 hours of transfusion, plus the time it took for the blood bank to prepare the matched blood for you. So this can be half a day to a whole day in the clinic just to get a blood transfusion. As well, allergic and transfusion reactions are fairly common with red blood cell transfusions. There can be fluid overload, both acute fluid overload called transfusion-associated cardiac overload or TACO that can result in the need for hospitalization, as well as worsening of heart failure symptoms where you have to take increased fluid pills because of all the fluid with red blood cell transfusions. And then a particular problem seen in up to 20% of patients is something called alloimmunization, where your body recognizes somebody else's red blood cells as foreign and starts making antibodies against those red blood cells. When that happens, you may have fewer donors in the general pool for blood, so it may be harder to get units of blood for you. And if you do happen to get a unit of blood for which you have antibodies directed, your body will not only attack that unit of blood, but sometimes will attack itself. It kind of gets confused and it will kill off your own red blood cells, and then you'll be even more anemic than you were before you got the blood transfusion. So this is a major problem. Red blood cells, all blood products, can carry infections. So recall that in the 1980s, patients with hemophilia were getting plasma-derived factor replacement, and that was actually contaminated with hepatitis C and HIV. So a large portion of hemophilics became infected by blood transfusions. This can also result in iron overload, which we'll talk about shortly, as well as increased mortality. In fact, this is pretty shocking. There's a 60% higher mortality risk in transfusion-dependent myelodysplastic syndrome than in transfusion-independent myelodysplastic syndrome. And that begs the question, is it because of the underlying MDS itself, or is it because of red blood cell transfusions? So to think about that, let's first think what's in a unit of red blood cells. So 1 unit of red blood cells is 300 milliliters. So that's a bag of blood. In that unit of red blood cells, there is hemoglobin that will increase your hemoglobin by 1 gram per deciliter. So if you started out at 7 grams per deciliter, 1 unit should increase your hemoglobin to 8 grams per deciliter. It will increase your hematocrit by roughly 3%. There is also a whopping 200 milligrams of iron per bag of blood. And the reason that's so shocking is that actually your normal daily oral absorption of iron is only 2 milligrams. So in a very short period of time, you can see that you can get a large bolus of iron and become iron overloaded with red blood cell transfusions. And then red blood cells can be stored in the blood bank for up to 42 days in a refrigerator. When they're sitting in the bag in the refrigerator, some of them get a bit unhappy and they start to have little pieces of their membrane break off. Those pieces of membrane are called extracellular vesicles, and they sometimes carry things like clotting factors that can increase the risk for blood clots. The red cells can also break open. They can just simply die, and they release the contents from inside of them into the bloodstream, which includes free hemoglobin, which can be pretty toxic to blood vessels, and then also inflammatory signals, which can send the body on high alert that there is a problem in the body and cause further fatigue and alert the immune system. So then the detrimental effects of red blood cell transfusions are possibly iron overload. So iron can deposit into organs such as the blood vessels, the liver, the bone marrow, where it can result in actually worsened ability to produce more red blood cells and fatigue. It can deposit in the heart and cause poor relaxation of the heart, which can lead to worsened congestive heart failure. And then if it doesn't deposit in the tissues, but there's an excess in circulation, just like iron in the environment can rust from oxidation, iron in the body can also rust and produce reactive oxygen species. Those are particularly harmful in the body. And reactive oxygen species can actually act on the stem cells in the bone marrow and lead to instability of the genome of those cells, cause further mutations, and ultimately progression or transformation to acute myeloid leukemia. So also the inflammatory signals or cytokines and those extracellular vesicles, the membranes of the red blood cells, can alert your body that there is something wrong. That can actually dampen your immune response to certain infections. And then the inflammation can cause further genomic instability and further contribute to this progression to acute myeloid leukemia. So, is that real, or is that just a hypothesis? Well, as it turns out, if you actually bind iron in patients to help scavenge it and get it out of the body so that there's not iron overload, you can improve survival in myelodysplastic syndromes. So this is a large study of 700 transfusion-dependent patients with MDS in Europe, and they're broken down here by received iron chelation in the dotted lines or did not receive iron chelation in the solid black line. And pretty strikingly, you can see that there is a dramatic increase in overall survival in those who received chelation therapy. So approximately 24 months overall survival in those who were not chelated, and approximately 48 months in those who received chelation. So double the overall survival. So suggesting that iron overload truly is contributing to toxicity within the body and leading to excess mortality. In the National Comprehensive Cancer Network guidelines, it recommends that if patients have had greater than 20 to 30 red blood cell transfusions, one should consider daily chelation therapy, either with a subcutaneous injection or an oral pill in patients who have lower risk myelodysplastic syndromes who may ultimately go on to a curative allogeneic stem cell transplant. And our goal of treatment is to get the ferritin levels, which are a marker of iron, to less than 1,000. So what about non-transfusion therapies for anemia? So first, to think about the non-transfusion therapies, I think we need to recall how blood cells are made in the body. So first is that your body likes to keep the amount of all cells in the body in a very tight range, because too few cells cause problems and too many cells cause problems. So the main organ that senses red blood cells in the body is actually the kidney. So the kidney gets signals of either hypoxia, which is low oxygen, or anemia, low red blood cells. And when it senses those, it sends a signal called erythropoietin circulating through the body, which goes to the bone marrow, and it stimulates the precursor red blood cells to make red blood cells. And as it increases the red blood cells, it feeds back. You have increased red blood cells, decreased anemia, less hypoxia, the amount of EPO decreases, and then you're making fewer red blood cells and your feedback loop is complete. In myelodysplastic syndrome, you may actually get stuck making the red blood cells because there can be maturation arrest within the early red blood cells all the way to the mature red blood cells. So there are several strategies to improve anemia and MDS aside from just giving back red blood cells. One of the big ones is actually using erythropoietin stimulating agents. So stimulates your body's own EPO, and essentially you're trying to overwhelm the bone marrow and tell it to really get it into gear and make more red blood cells. This is really effective if patients have an EPO level of less than 500. If the level is less than 500, there's about 50% likelihood of responding in improved hemoglobin levels with these treatments. If the EPO level, however, is above 500, very unlikely to respond and would not start with this treatment. Then there's a drug called luspatercept, which is a subcutaneous injection that takes the brake off the maturation arrest in the bone marrow and allows the red blood cells to continue maturing and ultimately getting out into the bloodstream. And luspatercept is predominantly indicated in those patients who have something called ring sideroblasts in the bone marrow, and a mutation called SF3B1. If they've not had a response to an erythropoietin stimulating agent, or if the serum erythropoietin level is greater than 500, because they're unlikely to have a response over here otherwise. This drug in these conditions has approximately 50% response rate as well. Then there's a pill called lenalidomide that is especially good in a condition of a chromosomal deletion called deletion 5q. So if you have deletion 5q and you have anemia and you take lenalidomide, you have about 70% will respond, and that response is pretty fast. It happens within just a few weeks. If you don't have the deletion 5q, but you have lower risk myelodysplastic syndrome that hasn't responded to other therapies, there's still about a 40% likelihood of response with lenalidomide, but this comes with lots of toxicity, including lowering the white blood cell count and potentially the platelet count, and putting patients at increased risk of infection. Then there's a big class of low-intensity chemotherapies called hypomethylating agents. These include azacitidine and decitabine. And this is predominantly indicated for patients with higher risk myelodysplastic syndromes. And notably, this induces about a 60% response in blood cell counts. So pretty good. It just takes a while to kick in. So generally, it's beyond 3 cycles, can be up to 12 cycles before you can see best cell count responses. So for these, you have to be a bit more patient. And then in some patients, actually, suppressing the immune system can be helpful. So in particular, those are patients who have hypoplastic MDS, which means that there are few cells in the bone marrow. If they have a particular phenotype called an HLA-DR15, or if they have this thing called a PNH clone, which is more likely to be autoimmune in nature. So if you have those features, immunosuppression generally results in 80% response rates to cytopenias. So do these other anemia treatments affect fatigue? Well, the erythropoietin stimulating agents have equivocal data. So there were some data suggesting that, yes, in fact, as they increase the hemoglobin, the fatigue also improves. But then just as many studies showing that with an increase in hemoglobin, there was no improvement in fatigue with administration of ESAs. Luspatercept is curious because although it can induce robust hemoglobin responses, it tends to not really affect fatigue. In fact, fatigue is more common in those treated with luspatercept than it was in the control arms in the studies. So it doesn't worsen fatigue. However, it doesn't seem to improve fatigue either, despite robust hemoglobin responses. Then notably, when you combine the low-intensity chemotherapies called hypomethylating agents with a chemotherapy pill called venetoclax, there has been report of improvement in fatigue, and actually pretty significant improvement if you look here. So both in dyspnea or shortness of breath and fatigue. Again, it's a little bit slow. So this is out to cycle 5 and seem to stay improved all the way out to about a year of treatment. Other fatigue mitigation strategies include 30-minute mindful breathing. So in a study of 80 patients with malignancy, 5% of whom had MDS, there were significant improvement in fatigue scores in those who did mindful breathing versus those in the control group. There was a pilot study of home-based exercise of 12 patients where they alternated aerobic activity with strength training. And by 12 weeks, they actually improved their endurance capacity. But more importantly, they didn't worsen fatigue. So it does seem like you can get some benefit from exercise programs and perhaps mindfulness in MDS. Again, these are all pretty small studies. In a survey of 145 MDS patients, most actually found the most helpful to be naps and energy preservation. So just kind of taking it easy in order to preserve energy for when you really need it. Notably, there are very few studies looking at stimulants. So things like methylphenidate or modafinil in myelodysplastic syndrome associated fatigue. There may be improvement. However, there is not enough literature out there to know. Acupuncture has also been studied in cancer-associated fatigue with improvements in some reports. So all potential strategies to try. So New Horizons, will we gain insights from this long COVID? So long COVID is marked by pretty significant fatigue that's chronic. And we're learning things about neuroinflammation and the pathways involved. And so hopeful that we can translate some of those into helping patients with fatigue from myelodysplastic syndromes. And then there's some interest in targeting mitochondrial energetics. So mitochondria are essentially the powerhouses of cells, and they become pretty disordered in many cancers, including myelodysplastic syndromes. There is a lot of consideration now about how to target those mitochondrial energetics to see if not only can you improve disease outcomes, but also improve quality of life. And so in summary, fatigue and anemia are very prevalent in myelodysplastic syndromes. Anemia may be associated with fatigue, either directly via decreased oxygen delivery to tissues or indirectly from an underlying inflammatory state. Blood transfusions can be helpful for anemia and fatigue, but come with significant risks, including increased risk of death and increased risk of iron overload. And so if you have had greater than 20 red blood cell transfusions, it is recommended that you consider iron chelation therapy. Some other medications can improve hemoglobin in MDS, but often do little for fatigue. And there's no clear treatment for mitigation of fatigue, but mindfulness, exercise, and napping or saving energy can help.
Thank you, Dr. Reeves, for your wonderful presentation, and thank you all for joining us today. For those who haven't sent in your questions, you can start submitting your questions in the chat box found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. All right, let's proceed to the live Q&A, and please bring your questions. Our first question, Dr. Reeves, comes from Kathy. She indicates that she's sorry, she's a bit confused. Can you tell her which category Aranesp is used in? And also, what is the average length of the time that it works? She's been on it for 2 years, keeping her hemoglobin at between 10 to 11. And she thanks you for your presentation.
Kathy, so Aranesp is actually an erythropoietin stimulating agent, or an ESA. So it's one of those medicines that actually is telling your body to make more blood cells by sending that hormone to the bone marrow. So the good news is if you are responding to the ESAs like ARNS, the likelihood that you'll keep responding for several years is really high. So it is likely if you've got a continued response that you will continue having that response for a couple more years. It's great news for you.
Thank you, Dr. Reeves. And in addition to her question, do patients get transfusion adverse reactions? And what complications can transfusions cause?
Yeah, so absolutely. Blood transfusions, while they're generally safe, especially if you don't need many blood transfusions, over time, you become subjected to the recurrent possibilities of the adverse effects of blood cell transfusions. And so with every transfusion, you have the risk of an allergic type reaction, of the fluid overload, of getting the wrong kind of blood, so blood that your body will recognize as foreign and destroy, and also of making those antibodies to future blood cells, limiting your ability to receive blood transfusions.
Thank you, Dr. Reeves. The next question comes from you. He wants to know, what about getting a blood transfusion to increase the red blood cells? And then raising the baseline with mindfulness, breathing, and exercise. His levels have currently really dropped down to 7.5.
Yeah, that's a great question. Can we combine therapies in order to really improve fatigue? So I don't think anybody's actually looked at that, but right, mindfulness is something that we can all do. Sure doesn't hurt to try. I think if your hemoglobin is 7.5 and you're pretty fatigued, it's certainly worth considering talking with your hematologist oncologist about getting that level a bit higher and seeing if you can maintain it. There's certainly no data to suggest that mindfulness by itself will keep the hemoglobin level boosted higher, although it's pretty clear in everybody that you talk to and every study that you read that there really is a mind-body connection. So the more positive thinking that you can do, the better the outcomes are in general.
Thank you. The next question comes from Sharon, and she wants to know if there is a major, I'm so sorry, does lenalidomide contribute to fatigue?
Yes. So every medicine, right, has potential benefits and risks. Lenalidomide is a pill that we use primarily in other cancers like multiple myeloma, but it's also used in myelodysplastic syndrome. And it tends to cause some diarrhea, can lead to fatigue, and also some lower blood cell counts. It can also boost the red blood cells. So many of these are double-edged swords in that they might boost your hemoglobin level, but they may not make you feel fantastic overall.
Thank you, Dr. Reeves. Diane has the next question. She knows there is a major risk with people of higher ages for bone marrow transplants. What is the mortality rate for those in their 80s? Will doctors even consider a transplant at that age?
Yeah, so caveat, I'm not a bone marrow transplanter, but here at UNC, we do perform bone marrow transplant for myelodysplastic syndromes and others. And when we're talking about the kind of bone marrow transplant called allogeneic stem cell transplantation, where you get blood cells from somebody else, wipe out your own stem cells, and then transfuse the other person's stem cells to take over your job. And there's significant risk with allogeneic stem cell transplant, especially in the first 100 days. And it worsens as a person ages. So while there's no absolute age cutoff for stem cell transplantation here in the US, and especially at centers like UNC, certainly that risk does go up. I would expect that the mortality is well over 30 to 50% in the 100-day mortality, but we'll have to get back to you with exact numbers from the transplant team.
Thank you, Dr. Reeves. Kay wants to know, do people with ringed sideroblasts ever get iron chelation?
That's another great question. So, to my knowledge, there has not been fantastic data showing that iron chelation can actually improve kind of the underlying bone marrow issue in patients with myelodysplastic syndrome and ringed sideroblasts. So many of times there's a mutation in a gene called SF3B1, and there's disordered handling of iron in the bone marrow, but it doesn't necessarily mean that you're iron overloaded. So iron chelation can also have some toxic effects. And so you have to be careful when kind of thinking about that. It's a great scientific question, but I don't think there's been any merit so far clinically.
Thank you. The next question comes from Erin. She would like to know what part low white blood cells and platelets play in fatigue, if any.
Yeah, I don't think it's really known. Certainly when you have cytopenias, often people experience fatigue. And what's not clear is whether that is because the bone marrow is trying to work really hard to make more blood cells, but those blood cells aren't really passing the quality control inspection by your body and the bone marrow, and they're kind of dying before they get out. So there's a lot of energy used in that quality control, or whether it's because the underlying disease process is kind of worse and leads to the increased cytopenias. But there's not been an absolute link between the white blood cells and platelets, but in general, we've kind of all observed this. It seems that people with the cytopenias do tend to be more fatigued. How that interplays with anything, nor how to fix it, is not exactly clear.
Thank you. Mary wants to know, when you said lenalidomide helps 70% of del(5q) patients within weeks, were you specifically referring to the fatigue or improvements in the blood count?
Improvements in blood counts. So the deletion 5q is pretty interesting, and it turns out that lenalidomide can actually preferentially target those cells that harbor the deletion 5q and actually cause them to die, leaving around kind of the good, healthy cells. And so you can get a little more fatigued with lenalidomide as you take it, but it generally, you start feeling improvement over time as the hemoglobin comes up and you need low doses of lenalidomide to keep things under control.
Thank you. Jeffrey is asking if you can define the physical symptoms of fatigue. Is fatigue the lack of energy to do anything, or the resulting winded, tired feeling after doing a physical chore and or periodic brownouts while seated at work?
Yeah, so it's curious. I actually thought about including a definition of fatigue in this talk. So it turns out fatigue, right, is pretty subjective in many ways, and some people interchangeably use fatigue and tiredness. And so I think it's curious that we talk about fatigue, yet standard definitions are not exactly there. In general, fatigue can be physical fatigue, it can be mental fatigue, and right, some people are just exhausted, fatigued at baseline, and some people just have increasing or decreasing exercise tolerance and are fatigued in that way. So it's a pretty broad definition. In the studies that I mentioned, there are validated questionnaires that ask people about fatigue. So it'll be like, how long are you able to perform physical activity before you have to stop? In a usual day, how would you rate your energy level on a scale from 0 to 10? And so while it's subjective, the data that we're using are validated and do have objective findings, but it's really physical, mental, it's kind of exhaustion all the time, or it can be intermittent.
Thank you. The next question comes from Susan. She's looking for a source of transfusion blood in the Toronto area that is not contaminated with COVID vaccine and antibodies. The reason why is because her brother suffers from MDS complicated by decades of chronic Lyme disease and co-infections such as bacterium, Mycoplasma systemic cryptococcus, among others. Due to the mycobacteria in particular, his hematologist advises that either the vaccine or antibody could be lethal to him.
I don't know much about the Canadian transfusion system. Here in the States, we would reach out to the Red Cross, but I don't know that we have any way of identifying whether or not patients who have donated blood have received COVID vaccine or have been exposed to COVID. At this point in time, I assume that 99+% of us have been exposed to COVID and probably have antibodies in circulation.
Thank you, Dr. Reeves. The next question comes from Janine. You mentioned dizziness. Is this part of NDS and fatigue?
So again, fatigue is pretty subjective, and sometimes people do sense fatigue in terms of dizziness. In general, though, we think about dizziness more as associated with either kind of the back of the brain or a cardiovascular issue.
Thank you. The next question is there any research looking at the Wim Hof method, WHM, which includes very intense breathing and cold exposure ice baths? I know there has been quite a bit of research on this with cancer, particularly in Europe, with incredible results. Do you know of anything like that happening in the States?
I haven't heard of that in the US. I think it's an interesting idea, but not aware of any ongoing research there.
Thank you, Dr. Reeves. The next question is from Ben. He was diagnosed as low, very low risk MDS 3 years ago, and he's watch and wait. His hemoglobin is in the 9.5 to 9.9 range. He walks 4 to 4.5 miles every day and does gentle yoga and swims a mile. He lives in Central Virginia, but he's spending the week on Emerald Isle in North Carolina. He's finding walking on the beach much more draining than walking at home, even early in the morning. Is this a cause for concern?
So I would say in general, it's not cause for concern. It sounds like your hemoglobin and general exercise tolerance has been very stable. Obviously, right, the beach is a bit different in terms of which muscles you're using and how active you are. So it's a little bit more difficult to walk on the beach because of the shifting sand and whatnot. So my suspicion is this is just an increased kind of physical challenge for your body. And if you return to walking at home, you'll be stable. So my guess is that everything is stable. Now, if you get back home and find that you're still having decreased exercise tolerance, then I would consider talking to your local hematologist oncologist about additional reasons for worsening fatigue.
Thank you, Dr. Reeves. The next question comes from Chris. He was diagnosed with intermediate risk, MDS unclassified. He's 51 years old with neutropenia, with only neutropenia so far. His hemoglobin, I'm so sorry, going back to the question, it just jumped. Sorry about that. His hemoglobin is around 13. Fatigue can be bad with him. He's exercising frequently to be in best shape possible for a stem cell transplant. Is there any downside to strenuous exercise?
Hey there. So it sounds like you are doing fantastic in terms of everything you can to be an outstanding transplant candidate. So great job. So in general, strenuous exercise is just fine, even with neutropenia. So neutropenia really places you at risk for infection. So as long as you're staying distanced and masking, things are okay there. In terms of strenuous exercise, right, you just need to be careful that you're not causing yourself tears to muscles. You're not putting unnecessary wear and tear on back and hips as we age. All of those things start wearing out. And if you need if you have back pain because of your strenuous exercise, that's going to decrease your exercise tolerance in the future and will negatively impact transplant. So I think if you're able to do it and you're otherwise in great physical shape, that sounds excellent, but otherwise would more recommend kind of moderate activity, maybe not running 10 miles a day.
Thank you, Dr. Reeves. Kay wants to know, do ring sideroblasts get counted as normal RBCs in CBC tests?
No, so ring sideroblasts are only found in the bone marrow. So you'll not find them on your complete blood counts when you have just blood work done.
Thank you. Sandra wants to know, she is saying, presuming the fatigue is because of the disease, or 2, the medications or the treatment, with an RBC of less than 10, her husband is not I'm sorry, I'm just trying to make sense of the sentence. Transfusions for her husband is not recommended as yet. However, his platelet count has been very low from the beginning, and he's had 2 transfusions. How does this help, given the platelets and transfusions has a short response span?
Trying to wrap my head around this one. So it sounds like your husband has low hemoglobin, but it's not been low enough yet that there's been consideration for red blood cell transfusions, but the platelets have been so low that he's had platelet transfusions. So the platelets don't last in circulation for very long. So in general, the lifespan of a platelet is about 7 days. So often you'll need repeated platelet transfusions, sometimes even a couple of times a month. Platelet transfusions aren't necessarily super beneficial for fatigue, as would be the red blood cells, but increasing your red blood cells won't necessarily also increase the time that your platelets last in circulation. So it sounds like his primary need is platelets at this point, not red blood cells.
Thank you. The next question is, what are the bad effects of luspatercept? Is diarrhea more common as an adverse event or more fatigue? At what number would you increase dosages after how much time, and when to stop it when the hemoglobin reaches what level?
Yeah, so in our experience, luspatercept has been pretty well tolerated. So high blood pressure is actually one of the things that we have to watch for with luspatercept. There can be diarrhea associated. And in the clinical trial, there was slightly more fatigue, but it wasn't clinically significant. I haven't seen increased fatigue in our hands and in our patients, but I also don't see improved fatigue with luspatercept, which is kind of disappointing. Luspatercept has defined kind of dosing intervals, and we're trying to get the hemoglobin generally to a level of 12. In the clinical trials, actually, some patients had to hold doses of luspatercept because they had such a robust response in their hemoglobin. It's really curious, though. I haven't been able to tell who's going to have those really amazing responses to luspatercept and who's going to have kind of those meh responses and who's going to have the little bit of diarrhea. In general, the diarrhea is not severe. The drug is pretty well tolerated and about a 50% chance of working, so not super terrible. The dosing interval and the dose is all kind of pre-specified by the manufacturer from the clinical trials and package insert. We haven't messed with the dosing strategy too much. We don't usually deviate a whole lot from what's in the package insert. But in certain people, you will find that you may need to shorten the interval a little bit or increase the interval a little bit to allow for better quality of life.
Thank you. The next question comes from Ken. He's wondering if hypomethylating agents such as Vidasa or Dacogen or Inqovi stop working, what are the options?
Yeah, so, and I presume you're talking about cytopenias in terms of the hypomethylating agents or the low blood counts. So some of the other options would be lenalidomide, which is the oral chemotherapy pill. And then there are options for intensive chemotherapy. So the IV chemotherapies where you'll often lose your hair. Clinical trial, of course, would be a consideration. We're starting to get more clinical trials, better kind of therapeutic options in MDS finally. And then stem cell transplant would be another option.
Thank you. The next question comes from Diane. She wants to know, do you know anything about the drug magrolimab, which has been called promising?
Yeah, so magrolimab is an antibody that kind of blocks this protein called CD47. It has been used in higher risk MDS and AML, and it does have incredibly promising results. I think the drug is kind of outside of the scope of this current presentation, but we and others have magrolimab in clinical trial, and happy to chat with you about it if you think you'd be a candidate.
Thank you, Dr. Reeves. Sandra has another question. She was the one who had a question about her husband. Really, his red blood cells weren't affected, primarily his platelets. And she's just trying to understand more about the benefit of having platelet transfusions, growth factors.
So platelet transfusions are really indicated if your platelets are less than 10 or 10,000, depending on which units you're using. So the benefit of platelet transfusions is really to decrease the risk of spontaneous bleeding. So platelets are in the body to really help the blood vessels seal up little cuts as we get them. So if you get a cut in one of your blood vessels, platelets come in, they stick to this really sticky Velcro called von Willebrand factor. They I call them the platelets bricks. They start building a brick wall around the cut, and they're filled in by mortar called fibrinogen. And so if you don't have bricks to build up the wall, then you can't stop bleeding. And so we know that in many patients, the risk for what we call spontaneous bleeding, or bleeding that's not provoked by anything like surgery or a cut, increases if your platelet count is less than 10. So in general, we're trying to keep the platelets above 10,000 with our platelet transfusions.
Thank you. The next question comes from Beth. You mentioned that iron chelation treatment should be considered if a patient has received 20 or more red blood cell transfusions. Would that be a lesser amount if a patient had a ferritin level of 900 due to ring sideroblasts before having any transfusions?
That's a great question. So these are always, so we have our guidelines, and then we have what we do in clinical practice, right? And so probably the ferritin that's 900 in the MDS with ring sideroblasts is not necessarily reflective of iron overload per se. And so there are other ways of measuring whether or not that ferritin is really clinically significant in terms of whether there's excess iron deposition in the body. So sometimes what we'll do is actually do fancy MRIs of the liver or heart to see if there's iron deposition there. Occasionally, we will do a liver biopsy to see if there's liver deposition there. Because there are risks with iron chelation as well, right? So in general, the iron chelation is really mostly indicated for those who have had lots of red blood cell transfusions, and not so much if the ferritin is just kind of 900 because of ring sideroblasts.
Thank you. Josette has a question. What kind of results have you seen with your patients taking Inclovy?
I'm not familiar with that medicine. What is let me see if I can find the generic name.
Yeah, Inclovy is the new oral pill, hypomethylating.
Gotcha. So they beat brand names out of us in medicine. So that is the decitabine, cedazuridine oral pill. So we don't have many patients who actually meet the criteria for taking the drug. So most of the time, our patients are still on the IV forms. When we have used it, we've seen very similar results to those with the subcutaneous or IV hypomethylating agents, which are pretty good responses to cytopenias. There's slight increase in the risk of GI toxicity with the oral decitabine, but it's generally pretty well tolerated.
Thank you, Dr. Reeves. If a patient is taking erythropoietin shots and it's working, should they expect that it will stop working at some point? And how long does it typically work, and what causes it to end?
Yeah, so in general, the response to erythropoietin stimulating agents is several years, which is, welcome news if you're one of those 50% who do respond to that. When they stop working, it can either be because you get antibodies to the medicine. So there are reports, especially in hemodialysis patients, that you can develop, your body will recognize the ESA as foreign and attack it, and then it can no longer work. And then another reason why it may stop working is that in the bone marrow, things are going to change over time. So if your bone marrow environment changes and you no longer have those red blood cell precursors for the ESA to stimulate, then it can become less effective. So when you lose response to something like Aranesp or darbepoetin, often what we'll do is a bone marrow biopsy just to check and see if anything has changed in there, so that we know where we're starting when considering next therapies.
Thank you, Dr. Reeves. Right now we know that there is a blood shortage, and then coupled with COVID. What is the current criteria used for getting a red blood cell transfusion?
Yeah, so our standard is actually if your hemoglobin is less than 8 as an outpatient, we'll give red blood cell transfusions. But I will say that although there's a shortage, we've been able to secure red blood cells for everyone who needs them. And there are some patients who just don't do well with hemoglobins of 7 and 8. And so on an individual basis, we may say, we're trying to keep your hemoglobin above 9 because you have underlying cardiovascular disease, or we really know that your hemoglobin, when it's greater than 10, you feel significantly better. So we're going to try to target that. Now, comes with risks, especially of iron overload, as we mentioned. And there's also a risk these days that we may not be able to hit those targets depending on what the supply is. But so far, even though we are in short supply, we've still been able to kind of have access to red blood cells and get what we need for our patients and not just have super strict transfusion thresholds.
Thank you, Dr. Reeves. Do you happen to know if you need to have a COVID vaccine before donating blood?
So I don't know the answer to that. I don't think you are required to have a COVID vaccine before donation.
Thank you. The next question is, what is the emphasis on knowing your IPSS score?
Yes, so your IPSS score is really the likelihood that your myelodysplastic syndrome is going to transform to acute leukemia, which correlates with overall survival. So really the whole treatment system for myelodysplastic syndromes as it currently stands is based on your risk of progression to acute leukemia. And that is because the only curative option we have for MDS at this point is allogeneic stem cell transplant, which comes with pretty significant risk. Now, you're willing to take more risk if you have higher risk to MDS, so your IPSS score is higher. So when you're looking then at your likelihood of acute leukemia and shortened overall survival versus stem cell transplant, you would be more likely to lean towards stem cell transplant in those higher risk MDS groups. But in the lower risk groups where the overall survival is significantly longer and the bigger issues are going to be cytopenias and fatigue, then you may not be willing to take the same risk on stem cell transplant outcomes. And so when we consider that in treatment guidelines, lower risk patients tend to get treated with kind of lower risk therapies. So that's going to be blood transfusions, it's going to be the ESAs, and sometimes even just observation. But the higher risk patients are more likely to get chemotherapies and referral for stem cell transplant.
Thank you, Dr. Reeves, for your thorough explanation. Norm has a question. He has low-risk MDS, and he wants to know, what does his doctor look for that might indicate any changes or progression that may have occurred?
Yeah, so essentially, we're kind of annoying when we see you in clinic, right? Because we want to know if anything's new or different. We want to know if you're having night sweats, if you're having bone pain, if you've had unintentional weight loss. All of those can be signs that there is something changing about what's the bone marrow environment. If your blood counts are really decreasing or the white count is increasing, those are all things that make us concerned that there is something else changing in the bone marrow. Depending on kind of the mutations that you have at baseline, we sometimes will also monitor the peripheral blood for additional mutations. So something called a molecular panel to see not only are there new mutations, but what is the percentage of cells that have these mutations around, kind of looking for what we call clonal evolution. So, but the big thing that we're looking for is how are you feeling and what are your blood counts doing? If your blood counts are really changing or you're starting to feel pretty crummy, those are all signs for us that we need to take a peek into the bone marrow to see if there's something else going on.
Thank you. Chris is asking if you could speak more about hematopoietic stem cell transplant, any risks versus the benefits.
Yeah, so not intelligently, Chris. So I am not a transplanter, but there is a significant risk of mortality, especially in the first 100 days with allogeneic stem cell transplant. And to get you good numbers, I'll have to talk to one of our transplanters, but we can post that on the Q&A after this.
Thank you, Dr. Reeves. Richard wants to know, where can he find his EPO levels?
Yeah, so actually EPO is a test that we do from the bloodstream. So if you are somebody with low hemoglobin, that and it's indicated that you might need to boost your hemoglobin, you should talk to your hematologist oncologist about checking your serum erythropoietin level. Usually turns around in about a week.
Thank you. The next question is, what is a biomarker, and will these be tested if you're considering a clinical trial?
I love it. Biomarkers can be lots of different things. So a biomarker could be something like lactate dehydrogenase or LDH. It could be molecular mutations in the cells. In general, though, biomarkers are things that we're looking at to see if we can correlate with disease risk and or response to therapy. So, right, our goal in medicine as we are advancing is that we're going to have personalized medicine where we don't have these general guidelines. We instead tailor everything to you. So the hope is to find biomarkers that help us guide those personalized medicine decisions. And currently, kind of the big biomarkers that we're using would be SF3B1 or the ring sideroblasts with the use of luspatercept. And then in the other molecular markers, those that mark for higher risk disease and might get you hypomethylating agents plus that chemotherapy pill called venetoclax.
Great answer. Thank you, Dr. Reeves. We still have time for questions, so I'm encouraging everyone to submit your questions in the chat box. Bring your questions. The next question is, if you can expand a little bit more, Dr. Reeves, an MDS diagnosis is based on what criteria?
So myelodysplastic syndrome is based on kind of clinical criteria. So usually it's there's concern for myelodysplastic syndrome because you have low blood counts, often low red blood cells or hemoglobin hematocrit. And then in the bone marrow itself, which is the factory where all of these blood cells are made, we are looking to see, is there evidence that any of these blood cells are abnormal? And typically when we talk about abnormal, we're talking dysplastic. So they don't look like normal healthy blood cells. And most of the time, we require that at least 10% of those cells look dysplastic. You can have some that kind of look ugly here and there, but really need 10% to make that diagnosis. We're also starting to incorporate the use of cytogenetic and molecular mutations as sign of myelodysplastic syndrome, although there are certainly flavors of myelodysplastic syndrome, and they're kind of pre-myelodysplastic syndromes in terms of things called clonal cytopenias of undetermined significance, where you have a mutation in the blood cells, you have low blood cell counts, but you don't yet have that dysplasia in the bone marrow.
Thank you, Dr. Reeves. Can you talk a bit more about what is immunotherapy in MDS?
Yeah, so in general, immunotherapy is where you are trying to get your body to recognize abnormal cells and get rid of them. So every day, our body will have some cell that comes about that's got a mutation. And in general, your body recognizes that cell as foreign, attacks it, gets rid of it, quality control, it's done, all is good. You're not getting a new cancer every day. But when you get something like myelodysplastic syndrome, your body is not recognizing those abnormal cells as abnormal and is allowing them to grow and expand, even though they shouldn't pass quality control. So there's been a lot of interest in kind of waking up your immune system with something called immunotherapy to direct your body to attack those cancer cells. And so you can imagine that is both very exciting, but also risky in some ways, because if your immune system wakes up too much, it might recognize your own body as foreign. It's exciting, though, in terms of the thoughts of being able to harness the ability of your body to target the abnormal stem cell by training it first. So things like CAR T therapy, where you take out your immune cells, you kind of train them in a dish to target something specific about your cancer, and then you give them back. So now you have a fully trained army to attack what's there. So all super promising, all likely to change how we treat myeloid disease and other malignancies in the near future, kind of still in its infancy, though.
Thank you, Dr. Reeves. Arthur has been living with MDS for 8 years, during which his red blood cell count size slowly reduced from 106 to the mid-90s. He's been on erythropoietin this whole time. Is there any significance in the change in red blood cell size? His hemoglobin is in the mid-9s.
Yeah, the first thing I think about, so in myelodysplastic syndrome, the red blood cell size is often increased, and the red blood cell size is reported on your complete blood count by the MCV, or mean cell volume. And so we believe that the MCV is often increased, again, because there's ineffective erythropoiesis in the bone marrow. So those cells are kind of sitting in there a little bit longer because your body's trying to decide, are these good enough to get out, or do they need to be killed here in the bone marrow? So over time, if the size of the red blood cells is getting smaller, what I generally would think of first is actually, are you developing iron deficiency for some reason? So if you're not somebody who's needed blood transfusions, is there some reason that your body may have used up its iron? So either dietary intake, drinking lots of coffee, and not having iron absorption that way. If you are a woman, we think about losing blood through menstrual cycles. And then kind of for all of us as we get older, we think about especially GI losses. So most of the iron in your body is stored in red blood cells, as you saw, and the way to lose iron, which is tightly regulated in the body, the biggest way to lose iron is actually from slow bleeding. And so if you had a little colon polyp, for instance, or a small bleeding stomach ulcer, those are all reasons that you could become iron deficient and the size of the red blood cells would decrease. So that's something I would certainly look into. I would first measure a serum ferritin. I would look at the blood cells under the microscope to see if it matches up with what we're seeing on the blood counter. And then I would consider colonoscopy and EGD for evaluation of iron deficiency blood losses.
Thank you, Dr. Reeves. The next question is, do the side effects of luspatercept lessen at all after 6 months of having used it, slightly or at all? And the second part of the question is, how often do you recommend getting repeat bone marrow tests?
So in those patients who have side effects from luspatercept, what I've seen is they tend to continue. So it's not one of those where you tend to get used to it from what we have experienced. So unfortunately, I think if you're having the GI toxicities, I don't think it's going to get significantly better kind of over time with you. Sometimes though, you can space out the luspatercept a bit more to give your body a bigger break from kind of the intervals between luspatercept, which helps some folks. So would consider that, but unfortunately doubt that your symptoms are going to get significantly better with ongoing luspatercept use.
Thank you. Mary was started on lenalidomide, 5 milligrams, after 3 months, her counts were all down, nothing improved. She also got a rash. She's speculating maybe from the Moderna shot. And so she stopped the treatment of lenalidomide. Now her doctor restarted her on lenalidomide, 5 mg every other day. How much time should she give this treatment again to see whether or not it's working?
Yeah, so, and I'm assuming, Mary, that you don't have the deletion 5q, because often lenalidomide works very quickly in that. So in the non-deletion 5q MDS, it tends to take several months for improvement in red blood cell counts from lenalidomide. And certainly rash is always tough. Rash can be associated with lenalidomide. Maybe it was exacerbated by the Moderna shot. Often the rash is not so severe with lenalidomide that we have to stop the drug entirely. Many times what we've tried is actually using low dose prednisone to see if we can get you through that. Sometimes H2 blockers, so antihistamines to decrease the rash. Usually though, we can get you through the rash. So need to give this a good couple more months to see if the 5 milligrams every other day is going to help. I will say that's a pretty low dose, so could take a little bit longer. I think if you're feeling really crummy on that after 3 months and there's zero improvement in the hemoglobin, would probably call that a good trial and think about something else.
Thank you, Dr. Reeves. Mary actually weighed in and she does have 5q minus deletion.
Gotcha. So with 5q minus, we tend to see results within the first 8 weeks. So if you're not seeing results then, would check to see if there's anything else going on. So is it just the 5q minus? Do you have other cytogenetic abnormalities? You're less likely to respond if you have other cytogenetic abnormalities in association.
Thank you. Beth has been on Aranesp for 5+ years before it stopped working. The next treatment she tried was luspatercept, but she had very bad side effects. And now she's transfusion dependent. What might be her next option to lessen the number of transfusions?
Yes, so kind of the commercially available stuff, depending on your risk of MDS, we would consider hypomethylating agents. So that's going to be the decitabine, azacitidine, and could consider lenalidomide if your other blood counts are otherwise okay.
Thank you. The next question is coming from someone who has the SF3B1 and TET2 mutations. They want to know whether these are mild versus severe. And the second part of the question is, if their ferritin levels rise, what does one do if the patient is already at stage 3 or 4 renal insufficiency? Would chelation, would it be a choice?
Yeah. So you're astutely pointing out that different mutations have different sort of prognostic implications in terms of risk of progression to acute leukemia, as well as sometimes even response to therapies. So in general, the SF3B1 and TET2 are what we call lower risk mutations, meaning they have a lower chance of developing to acute myeloid leukemia. It's certainly not 0%, but in all of the prognostic models, they do tend to be on the lower side. And then in terms of renal failure and iron chelation, so you're right. So we have to be careful with many of our preparations of iron chelation because some of them cannot be used if there's renal failure. There is at least one that we can use. It's not the easiest to get approved for MDS iron overload, but there is one available, and would consider that if you had significant iron overload yet stage 3 or 4 kidney disease.
Thank you, Dr. Reeves. Chris wants you to expand a little bit more on the advised frequency on getting a bone marrow biopsy, maybe even weighing in on those in the low risk versus those that may be in the intermediate to higher risk, the frequency.
Yeah, so in general, I don't put people on a schedule of defined bone marrow biopsies. So it's not like you get one every 6 months or every year. Really, mostly looking at the clinical picture. So outside of a clinical trial where there are defined times for bone marrow biopsy, the big thing really is how are you doing? What are your blood cell counts doing? And how are you feeling in general? Because generally, if you don't have any changes in symptoms or counts, we're unlikely to find anything new or concerning from bone marrow biopsy.
Thank you. We still have time for a few more questions, so I just want to let you know. Please enter your questions in the chat box. The next question is, does MDS always turn into leukemia?
That's a fantastic question. So, one thinks that the natural history should be such that if given the time, it would turn into an acute leukemia. So these are pre-leukemia states. Yet, not everybody with MDS will progress to acute leukemia in their lifetime. So that's good news in many ways, right? Because it would suggest that there are lower risk myelodysplastic syndromes where it's more of a chronic issue and unlikely to turn into anything acute and life-threatening. It can still be life-altering. But then there are others that are going to develop into acute leukemia much more quickly. And so one of the big things that we're looking at is, can we better identify those? You've probably seen some buzz about refining our prognostic risk model, so updating that IPSS model to include those genetic risks to better stratify and understand who's who there.
Thank you, Dr. Reeves. The next question is, what is the name of the therapy you might use for those with renal failure regarding ferritin levels that you alluded to before?
Yeah, so you can't use things like Jade News. So there's Ferroprox and a couple other preparations. You just need to talk to your hematologist oncologist and the clinical pharmacist about your kidney function and the options you have available, including your insurance coverage. And they have to do prior authorization to see if those things are available for you.
Thank you, Dr. Reeves. So thank you, everyone. That's all the time that we have for questions. It was a great talk and very thorough overview of the disease landscape. And thank you all for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or you would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.
Bye.